the term recovery avoidance in no way implies that that's their intention, that they're trying to screw up their therapy or their recovery. It really describes the functional outcome. The effect of the behavior is recovery avoidance. It's not the intention. What minimizing does is create conflict and distrust. And so when we come across and we don't get it, when you start lecturing them or prodding them or like, you don't get it. This is not something I can just snap out of. That's the feeling that they get. So there's distrust. So you think about when you live or interact with people who don't get it, your anxiety is going up. And when your anxiety is going up, you're more likely, if you're already avoidant, you're more likely to be recovery avoidant. And as long as you stay in the trap, you are going to behave the same way. The only way out is to escape. And that means doing things in your control and the things that you need to change to get out of the trap.
Hi, everyone, and welcome once again to another episode of the Get to Know OCD podcast. It is a special day for me because we have Alec Pollard here, who was my mentor. Some of you may blame for the reason I do what I do, but I say a life-changing, momentous occasion of getting into the St. Louis Behavioral Medicine Institute and getting to work with Alec as a postdoc for 2 years. And I just always love to tell a funny story about Alec and the interview that I had, which was about 1 minute of psychology and 29 minutes of why we both dislike the Cubs. And that was odd, I thought, but fun at the same time. And at the end of the first year of postdoc, I said to Alec, that interview was weird. And he gave what I think is a classic Alec reply, which was, I knew I could train you. I just had to know that I wanted to. And I'm glad you wanted to, Alec. So thank you for joining us today. Good to see you.
Well, thanks a lot. Well, no Cubs fans will ever apply for our fellowship now. Thanks a lot, Patrick.
Sorry, I've ruined it for you. My apologies. But growing up as a White Sox fan myself, and you as a Cardinals fan, yes, there was some mutual baseball to discuss there for sure.
Absolutely.
Yeah. Mm-hmm.
And both of us are kind of sad this year, really.
Yeah, terribly. Maybe me more than anyone, yeah, but rough year. So could you tell everybody a little bit about yourself and really maybe just a short kind of intro into St. Louis Behavioral Medicine, the development of it, and where it's at today? I think that'd be cool.
Well, I'll do a quick one.
Yeah.
So I came to St. Louis from Philadelphia, where I did my postdoc. And that was my sort of drink the Kool-Aid experience, just like yours was. Mm-hmm. And started the anxiety. We actually started as a phobia treatment center because we thought it would be too controversial in what had been traditionally a largely psychodynamic department to start with an anxiety disorder center. So we made it a phobia center because phobias at the time were okay for cognitive behavioral therapists to treat from a dynamic perspective. And it was sort of less threatening. So we did our first year. I don't know if I've ever mentioned that, but our first year we were the phobia center. And then got comfortable. Everybody knew us. We didn't have 3 heads and we weren't weird. Well, any more weird than, the rest of them.
Yeah. Right.
Yeah. And so then overnight, we just changed the name to Anxiety Disorder Center. We didn't make any announcement. Just sort of snuck in. And then we were there for 13 years, a group of us in the Division of Behavioral Medicine, Department of Psychiatry and Human Behavior. And then we moved and formed the Institute, still affiliated with the university. But we had a lot more freedom, and there were a lot of other advantages to doing the Institute. But we've always been a group of specialized programs. When DSM-5 changed, we changed our name from the Anxiety Disorder Center to the Center for OCD and Anxiety-Related Disorders, which a lot of people did.
Yeah.
because DSM-5 just goofed it all up for us, anxiety clinics. Uh, and so, and then been there ever since. About 6 or 7 years ago, I went emeritus at the university, largely because I didn't like being on committees. Um,
You
uh,
never have, really.
no. And that's been a great liberation. But I'm still affiliated with the university. And in about 2 years, well, almost, I guess, 2.5 now, I gave the reins of the clinic to Dr. Allison Minotti, who's terrific. She's the new director, and I am now the founding director. Now, many of your audience is probably wondering just what does a
Yeah.
founding director do? And I know it's mind-boggling. It's very complex. I would go into it, but this is only an hour show, right?
Only an hour. Yeah.
Okay.
Yeah.
Yeah. So it's I'll send the almanac to everybody
Very
that
good. Very good.
describes in detail,
Yes.
groundbreakings for new buildings, bothering the support staff. It's an ongoing list of,
Napping, I believe, is in there.
yes. Yeah. Very important. So basically, I'm doing the things that I love to do and like to do, and I'm not doing any of the things I don't like to do. And that's pretty cool when you're 39 years old. You can accomplish that when you're 39 years old. And if I had accomplished it when I was 39, it would have been a nice thing. But
Yeah.
okay, I'm a touch older. Well, at any rate, so we've been there all this time and been doing clinical work, some research, writing, that kind of stuff. Yeah.
Awesome. Well, thank you for that history. And I think probably in addition to being an award winner, as you are, just the accolades continue to pour in at every conference you go to, many of which award ceremonies you do show up to. One or two you might miss randomly. I don't
Yeah.
know what I'm talking about there or anything. But
Yeah. 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 Thanks for bringing that sore spot up again. Thanks, Patrick.
yes,
Yeah.
I was giving an award to Alec and was told as I was walking on stage to give it to him that he wasn't there. And it turned out he was sipping some drink probably on a balcony looking at an ocean or something.
Well, I will say this, this is probably my most notable legacy.
Yes.
ADAA now actually informs the award recipients that they're getting an award. It's no longer a surprise.
No.
And I changed that whole tradition. I'm
Yes.
very proud of that.
Well, I'm proud too.
It's my singular accomplishment.
But you have had another accomplishment recently. There is a book out that you and a host of people collaborated on called When a Loved One Won't Seek Mental Health Treatment, How to Promote Recovery and Reclaim Your Family's Well-Being. And I'd just be interested in kind of the genesis of that and where that came from and where you hope to take it.
Well, thank you. And thank you for having me, by the way, because I really have been enjoying talking about this book and the work that we're doing because it's kind of a mission for me at this point. So, a few decades ago, we started sharing our experiences with really what every therapist probably experiences. A family member calls in and says, my husband, my child, my parent has a severe illness. At the time, it was mostly OCD, sometimes hoarding as well. And they say, well, they don't think they have a problem or they won't get help. What can you do? And we just turn them away. And that was a bit unsatisfying. And so we're not griping about the families calling us, but griping about that we have to turn them away. And so we started sharing ideas over the staffing table, and it just sort of organically grew to decide, well, let's see what we can do for families. And I've always had a side interest of family interaction professionally, and so we started developing some interventions to help the families of the people dealing with what we at the time called treatment refusers.
Mm-hmm.
We now use the term recovery avoiders, and we could get into why that is and all of that. But Um, and so then we got a grant from the foundation, OCD Foundation, I should say, International OCD Foundation, and we did a pilot study compared to a placebo control group, and we were able to significantly reduce accommodations in families without having to see the person who's a treatment refuser, which is very fortunate because, as you might imagine, a treatment refuser probably doesn't show up at sessions very often
No.
because they are a refuser. So believe me, we had to deal with this with the IRB. We had the unique distinction of having the IRB proposal that during that year, whatever that was, took up the most time of the med school IRB committee.
Really?
Yeah, of
Wow.
any other IRB proposal. And now, mind you, they're diddling people's brains and they're invading bodies with all sorts of good research. Don't get me wrong,
Right.
but our study, and they got hung up on the idea that the treatment refuser had to sign the consent form, and, and I don't know if you saw both parts of that phrase, treatment refuser. Yeah,
And
so
informed consent. Yeah. Yeah.
they're not. First of all, we're not treating them, but it took
No.
a while for them to get their head around that. We're not treating them, at least not directly. We're treating the family, and they're a refuser. So
Yes.
you pretty much blocked our study out, which we've already got funding for.
Mm-hmm.
So we worked through that, and there were a couple of other minor things, but we finally worked it out with the committee. But I just thought it was funny that this, what I see as a pretty benign family intervention study, got all this attention from the IRB. But we finally got it approved. We did the study. We learned a lot from the study, and we also learned what we were missing. We learned that we were the basic components were good. We are going to keep them, but we learned that we're a little naive because it was originally called brief family intervention,
Oh.
and it's not always brief.
Mm-hmm.
These are entrenched patterns in families, and they're very, very some families very, very impaired, and so we can't really call it brief. Sometimes it is, but it's not necessarily. We also learned some things we were missing, like valued activities, and spending more time trying to, because many of these families had sort of pulled away from the things in their life because they were dealing with the loved one who had the mental illness, and they'd really lost a lot of the stuff that brought them meaning and replenishment. And so we really added that component to the protocol.
Yeah.
We also changed. We were always dealing with preparing them for crises, but we moved that up to the very first step to get that in place before they tried to make any other changes, that they had to have a really good, solid plan and commit to how they were going to deal with crises, because that's the number one thing that makes them not follow through.
And those will happen when you start removing safety behaviors, I would assume. Yeah.
Exactly. Yeah. And it can get pretty dramatic and pretty scary for the family. So, and I get it. I mean, as much as I push them, you've got to follow through with this. I get their reluctances, and it's terribly frightening when somebody is threatening to harm themselves or getting physically aggressive or damaging valued property. That's scary stuff, and but important for them to deal with. So one thing I really hope families take from the book is, number one, to understand they're not alone, and number two, to have some hope or optimism that there are things they can do other than waiting for their loved one to get better or trying to force them into getting better. There are some options that are more effective and also will improve of your lives as well.
Were there common themes you were hearing from families about why their loved ones were not wanting treatment?
Um, yeah, I mean, although it's interesting because this term that we have come up with for this range of behaviors called recovery
Yeah.
avoidance, which means maybe it'll take a minute here to
Yeah.
define it.
Let's do that. Actually, that's
Yeah,
probably good. And it will
because
form our questions better too. Mhm.
yeah, so recovery avoidance it refers to behave a pattern of behavior that's incompatible with recovery,
Okay.
and so like if there's a new treatment available for your condition, you don't seek it out. So recovery avoiders could be people who say, "I don't even have a problem. So what are you talking about?"
Hmm.
They could be people who say, "Okay, I have a problem, but it's not psychiatric. It's just a quirk."
Hmm.
So they downplay the severity of it. They say they have a problem, and yes, they acknowledge it's psychiatric, but they're going to handle it themselves,
Hmm.
which they end up not doing. Um, or okay, it is a problem and it is psychiatric. And then they go to all these wrong therapies. Like instead of going to the ones that are more evidence based, they're putting garlic around their neck or they're screaming into a pillow, which, by the way, I highly recommend, but not as a treatment for OCD.
Right.
Um, so, but it's really good when your favorite sports team is losing.
Yes. Yes. Exactly.
Okay, remember that when they watch the next White Sox game. Pillow.
Thankfully, they're done. So yeah,
Yeah,
that's
works good. Yeah.
yeah. Mhm.
Uh, so uh, so there's a whole range, and then finally there are people who show up for treatment sessions but don't seem to ever take advantage of it, and that all of those folks are fit into what we call recovery avoiders. And to be clear now for our audience here, the term recovery avoidance in no way implies that that's their intention, that they're trying to screw up their therapy
Correct.
or their recovery.
Right.
That's not the, it really describes the functional outcome of the effect of the behavior is recovery avoidance. It's not the intention. There are real factors that drive recovery avoidance, and often families, because they don't understand this, attribute their behavior to willfulness or laziness or negative uh, labels like that don't really tell us anything about what's really driving the behavior, and certainly don't tell us what to do about the behavior. And even worse, these labels justify them engaging in one of the behaviors that we try to get them to stop doing,
Okay.
which is called minimizing. And that actually makes things worse, which, as I'm sure we'll get into. But um, so, so that's recovery avoidance. It's any pattern of. It's got to be a pattern of behavior. It can't be like one day, but
Right.
that really keeps them away. And everybody has a little bit of this. Let's just be clear. It's
Sure.
not these are some weird alien human beings different than the rest of us. We all have our own form of recovery avoidance, and everybody out there probably has had trouble doing something that's healthy or the doctor told them to do, whether it's exercise, diet, shaking a bad habit. And those of you out there right now, how many of you floss twice a day as your dentist suggests you do? Come on, you know, Patrick.
I do not. I will say.
No. Well, I
Mhm.
remember one. I state when I'm doing a talk on this. One time, this lady raised her hand and said, "No, I floss twice a day." I said, "All right, you sit down. You're making the rest of us feel bad.
Yeah. Exactly.
No, that's not right." But normally we don't. Um, so, at any rate, that's recovery avoidance. And so, as we talk about that, so you were asking me what prior, I believe.
Well, just some of the reasons behind people avoiding recovery, right? What would be some of the things that the families have maybe brought up to you and said, maybe this is why they don't want to do it, or maybe the families are just stuck and they don't even know. I mean, I'm just
They don't
interested
really.
what you're hearing from the families, really.
Well, yeah, you can divide this into two categories. What the um, what the recovery avoider says to the family.
Oh, okay.
Then you've got what the family comes up with. So the recovery
Oh,
avoider
sure.
might say, um, they might say, I don't have a problem or whatever. They're actually often clueless about what's really driving their behavior, to be honest. And then the family member, when they hear something like, well, I don't have a problem, then they start to think, well, this guy's maybe he's not in touch with reality,
Yeah.
or they come up with their own theories, usually pejorative, and which I understand because this is tremendously stressful for the families.
Of course.
But like I was saying before, they're lazy, they're willful, oppositional, always something kind of negative, and not. Now, if we get to what are the real reasons, what are the real things that actually drive the behavior, not what the recovery avoider is aware of, not what the family. There are things like skill deficits, like some
Okay.
people just really bad at organizing their behavior. So, for example, just to make a simple phone call to set up an appointment with a provider involves often researching, trying to find a provider, and that's not easy these days. It takes work. And then making a decision, which some of our patients struggle with, the decisiveness about like who am I going to go to, then following through with, and then actually showing up for the appointment. So even the simple act of just making an appointment can be involve skills that some folks are not terribly good at. There's also belief systems that people hold. Some people believe that all medicine is poison, for example.
Mm-hmm. Mm-hmm.
And so why would I ever take medication because it's poison? And they're really locked into that. There's also motivational deficits. Not everyone has a vision of their future. And so motivation are those long-term, the desire to reach long-term goals, which most people have. So if those who have psychiatric conditions, if they yearn to be able to go to college or have a family, have relationships, they have motivation because often their problems are interfering with those things. But someone who doesn't have those goals, has no vision for their future, is probably going to lack the motivation that really drives someone to try to get help. And then there's also what we would call incentive deficits, and what that means is incentives are those daily kinds of rewards and punishments that drive a lot of behavior. And if the families, and this is where it gets into how the family affects that, if the families are protecting them from the consequences of the decision to not get help or to not move towards recovery, then they're actually taking away the motivation potentially for that person to go get help, because we don't get help just to be a better person. And I always make the joke that, except in California, but otherwise, most of the other states and parts of California, we go when we're hurting, and that drives us to go get help. And when do we hurt? We hurt right now. But if that's blunted, then so is our motivation to go get help. So those are just a few examples of the real factors that
Sure.
drive.
On the flip side, uh, what are things you're hearing from families about just where they're at? There's got to be a level of desperation and overwhelm that you're hearing in the calls that they're making to you to discuss what to do.
Oh my gosh, yeah, and it can range. The level of impairment can range everything from. Uh, I've got a cousin who lives across the country, and I'm worried about him. Their own lives are not affected at all. They just are sincerely worried about their cousin. That's sort of a minimal impact. Then you can have he or she living in my house, causing turmoil every single day. I can't do this. I can't do that. That's at the extreme level of distress and everything in between. So the families that are the most impaired as a family are often the ones who are living with um,
Hmm.
the person who has the and I often say the psychiatric condition or the mental illness, but we started this work with OCD, and that's kind of our topic today. But we expanded it beyond because we realized we were doing stuff with families of people with social anxiety or
Sure.
panic or agoraphobia or depression. And so the book that we wrote, we started it being on OCD, and we quickly decided to expand it to really help more families dealing with
That
this.
makes a lot of sense. Yeah. Because it wouldn't just be people with OCD, obviously. This is a universal issue potentially.
Absolutely, yeah. Um, and and so we can't say we've tested it with families of every with a loved one with every disorder, but a lot of them. And I think the most important thing, whether these principles will help families, is less what the disorder is that their loved one has and more their situation. If they're in a kid, if they the families we help tend to have these characteristics, there's somebody in their family with one or more mental illnesses, and as you know, Patrick, it's more often two or more
Yeah.
conditions. Uh, it's very, very common to have multiple conditions. Um, that person has to be in some way avoiding recovery from that, either denying that's a problem, refusing help, or going to help but not participating in the therapy. Um, that refusal, that recovery avoidance, has to be impacting the family sufficiently that it's impairing their lives either through distress or impairment actually interfering with their functioning. And they have to be willing to try something new. Um,
Yeah. Well, which can be equally hard probably for families as it is for the recovery avoiders, right?
yeah, no, they because they want so badly, and I would too if I were in their shoes. They want so badly to have us tell them the magic thing to say
Yeah.
to the recovery avoider that will make them snap out of it. And sadly, we don't have that. Um, if we did, I'd be charging a hell of a lot more for the book. Just want you to know
Per
that.
session, right? Yeah.
And per session, yeah, yeah. So, but what we do have are some very powerful interventions that can help them improve the well-being of the entire family,
Sure.
and indirectly, and sometimes eventually directly, help move the recovery avoider towards recovery.
There's also got to be families, I'm assuming, that come in pretty hot and just can you just tell them to stop it or figure it out? How do you maybe walk through a little bit of what are some of those conversations with families and the education that you have to do with families to get them ready to do this? I often joke many people, the recovery avoiders as well, are fixing to get ready to do something instead of ready to do something. So how do you move somebody past fixing to get ready to do it and actually doing it is what I'm interested in.
Well, it's a good question. Before we had written anything up and we were just following our emerging protocol, we would have to see families for multiple sessions before we realized they weren't a good fit. They just weren't there yet.
Okay.
Um, and and so our time spent with families was not very efficient. Since we've written the book, but even before then, we had drafts of the first few chapters. We would send it to them
Hmm.
when they asked about help send it to them. And then we said, after you read those chapters, if you want what we have to offer, because they'll know by then,
Sure.
call us back.
Mm-hmm.
But you have to read the chapter, whatever we sent them first. That has made life so much nicer for the therapist. And I think that's what we're here for, right? Is to make life nice for therapists.
Yeah, of course.
Because we felt like once they kind of went through that, we knew who we were getting was really on board, and we were weeding out, because the folks wouldn't call back if they didn't see some magic answer. But the folks who really get that this is about, read the material, they see we have a chance to improve the lives of everyone else, and maybe indirectly the recovery avoider. That seems so much better than what we're doing now. The ones who get that would call us, and then it was really they did. Most families have done really well because they're on board, and our time is more efficiently spent because we're getting people who are really on board by the time they come into our consultations.
Are these all done virtually? Do you do some one-on-one live, or does it just depend?
It's just like our clinic. We do live, we do virtual, and I'm hoping, and we've had some reports that, and maybe at some point we can do a study, but we're certainly hoping that some families won't need consultation. They can just follow the steps in the book, and we're optimistic that that's the case. Or what I could see being efficient and realistic is they use the book, and then they have a therapist they can call when they get stuck.
Sure.
And that would really be a very efficient use in this day and age when therapists are hard to get into and overbooked. That would be a really efficient model, I think.
Yeah. Well, maybe if they wouldn't all go emeritus, they would have more time on their schedule or something to see people.
That's the one thing I didn't cut back on so much was seeing patients.
Yeah, because you actually like that versus committees.
I do like that. Yeah, I still go to college basketball games too. So there's not as part of my job, but so I'm doing more of what I like. Yeah. Mm.
Since we're focused on OCD, you started this all with OCD. Are there some common themes that you see in family members of recovery avoiders that you're dealing with pretty typically in an OCD case?
Yeah. In fact, the steps that we put together kind of reflect what we learned about the common issues. So we've tried to address the common issues. The two main things that families do, which is accommodating and minimizing, those are the terms that we use for how the family deals. Both of them have costs. They're toxic. Right. Mm-hmm. But the family member doesn't know that. The family member starts off, right, I'm going to help this person.
Sure.
And there's a person who needs help. And the family natural response, and that's what most families do. They just they react out of instinct to try to help, and they do so in two ways. They try to assist them to get something done, whether it's get up in the morning or finish their breakfast, and then they try to persuade them to do better, to take on challenges, just like a coach does.
Sure.
Those are two things. And with someone who's not a recovery avoider, those things are very effective strategies. But the problem is that assisting someone with a recovery avoider devolves into accommodation.
Of course.
Bad accommodation, not the good stuff.
Yeah.
And then trying to persuade someone to do better, it devolves into what we call minimizing. And that's the thing where people are prodding the person, lecturing them, criticizing them, blowing up, yelling, screaming, sometimes even nice behavior like coaching them or trying to cheer them up. Those are all minimizing behaviors. And we call it minimizing because it underestimates the forces that are driving the behavior and sort of gives the message that somehow you can snap out of this. If I say the right thing or do the right thing, you'll just snap out of this. And that's why we call it minimizing the severity of the challenge that the recovery avoider is going through.
Sure.
And so minimizing is any ineffectual attempt that you repeat over and over again to try to change the person with the impairment. And then accommodating, I think probably your listeners are probably much more familiar with that term, accommodations. But that's when we adjust our behavior to try to compensate for or respond to the demands of a person who's impaired. And, that's everything from doing their homework for them to getting them up in the morning, you name it. So both of those things start off as really well-intentioned, normal behaviors, but it's a toxic interaction, because what accommodating does is make them more dependent and often entitled, and then less likely to go get help.
Yeah.
What minimizing does is create conflict and distrust. And so when we come across and we don't get it, that's what the recovery avoider feels when you start lecturing them or prodding them or like, you don't get it. This is not something I can just snap out of. They don't think that way, but that's the feeling that they get. So there's distrust. And so that distrust and greater anxiety around people that don't get it. So you think about when you live or interact with people who don't get it, your anxiety is going up. And when your anxiety is going up, you're more likely, if you're already avoidant, you're more likely to be recovery avoidant. And so all of those cycles interplay. And the one last piece of this is all what we call the family trap.
Okay.
Is this, as more you accommodate, the more you're going to be burdened. And that's going to make you emotionally under emotional duress, which leads you to minimize more because you're going to be more cranky. You're going to be less tolerant of their condition and resort to the minimizing strategies that, and I want to say accommodating and minimizing both don't work. But more than that, it's more than they don't work. See, because everybody in the family, when our families come in, they're not claiming their strategies are working.
Right.
When we say, well, it doesn't work, does it? They don't argue. They go, you're right, it doesn't work. The part that's a little harder to understand is it's making things worse.
Yeah.
It's not just not working. It's not benign. It's making things worse by reinforcing recovery avoidance. And then they have to keep responding to the recovery avoidance the only way they know how. And it's just a big cycle of self-fulfilling, mutually perpetuating behavior. And
I think it's important to make clear, you are not blaming families for any of the behaviors that they've done because they didn't know what to do. Right. Yeah.
No. It's totally nobody. We had no course in high school. I didn't, about how to deal with a mentally impaired family member, much less somebody who's a recovery avoider. So they're doing what's instinctive,
right,
and it's completely natural. And that's, we try to get the point across that the same principles apply to both the recovery avoider and the family. You guys, nobody set out to do this on purpose. You didn't know, and you couldn't have known. And so it just, the way it evolves. And as long as you stay in the trap, you are going to behave the same way. The only way out is to escape. And that means doing things in your control and that means focusing on your own behavior and the things that you need to change to get out of the trap.
Yeah. Yeah. That I know in my own discussions with families that there's a lot of shame and guilt that they feel even when they realize, oh no, was I playing into the OCD or the condition, that
Yeah,
sometimes we have to spend a good chunk of a session just on that piece, that because
yes,
they're feeling so terrible about
absolutely. And we try in the book to get that message across.
it. Yeah.
I think we do, but it's so important to emphasize, and I'm glad you brought it up. Um, so the way to say it is that uh, we families don't ever cause someone to have a
Right.
mental illness. We've rejected that. That was a theory many years ago. It long been rejected and uh, disqualified. But they can influence the development and the
Sure.
direction of their disorder by how they respond. Certainly can, and that's not limited to psychiatric conditions. You know, I can influence if I have a family member who has um, a medical problem that requires taking their medicine on time and whatever. How I respond to that can make a difference in whether they become good at self-regulating and taking their medicine, or whether they become dependent on me to do it and then struggle when I'm not around if to be able to take their medicine, for example.
Hmm.
So no, it's absolutely um, never is anybody's intention, nor is it their fault. But they do have opportunities to improve the quality of their lives and even the recovery voider.
Yeah. And it is so difficult, I think, for the families who feel stuck, they feel alone, but it's also got to be amazing for them to speak to you or read the book and finally realize maybe there's other people out there like them. They're not the only family struggling with this. They aren't failures as spouses or parents or grandparents or children or anything like that, right?
Yeah, I think that's absolutely right. It's very confirming and destigmatizing,
Yeah.
I hope, for them, because I can't tell you how many families have said, "You wrote that book about us, didn't you?"
You were spying through our window. I know you were.
I didn't know you till 2 weeks ago,
Right.
so that would be kind of hard. But it's very validating for us to hear so many families say, "God, you're talking about our family." Um, and I even have one recovery avoider who read the book, um, the son of a couple that I'm seeing, and and he swore that the book was written about their family, and he was doing it in a defiant way, like, "How dare you write about our family?" And
Yeah.
his parents were reminding him that the book was already out before he started seeing us,
Oh,
so
okay.
that was very difficult.
It would be. Although you have spies, I know, so
We do,
that are out there.
we do. Yeah,
Hmm.
yeah. Well, don't give that away.
I'm sorry, I
Thanks.
forgot. There are no
Yeah,
spies. There's no spies.
you're endangering their
Yeah,
lives,
that's right.
working undercover.
We're not revealing any names.
Yeah.
Black sedan following you. Yeah, who
Well, we've
knows?
lost another couple. Dr. Shabuki's gone. Thanks to McGrath giving away his cover. Yeah. So,
Do you see this as kind of a potentially next frontier as we look at treatment and recognizing the role of the system? Obviously, we have systems based treatments that are out there that have always looked at this, but I think you've narrowed in on a part of this with the refusal piece that not really anyone else has touched, right? Maybe like, I'm not going there, but you went there. So how do you see that this could be influential in the future for treatment for families and people who are suffering?
well, we really hope so. I mean, the reason we got interested in this is because no one else at the time was addressing it.
Right.
The closest thing to what we're doing is in the substance use field. And they were kind of ahead of the mental illness field, and because they had so often, I believe, were dealing with denial and refusal, and so it's not surprising that things like Al-Anon, grew out
Yeah.
of that, and motivational interviewing, and the family intervention, and those kinds of things. And now what's called the craft model um, is sort of integrating a lot of those principles with families of substance users. Now, the craft model wasn't around that we knew of when we started developing our model. They were
Mm-hmm.
sort of simultaneous, although they've been out, been published longer. And they're very similar kinds of things, not exactly the same, but kind of interesting to see, and you see this sometimes where people will be in their own labs working on a similar problem, and they don't know that the other person is doing something similar, and then what they end up working with, for good reason, and what they end up producing sometimes are similar, or
Yep.
at least have a lot of overlap. There are some other people in the OCD field that have worked on um, uh, sort of in recent years family interventions that are applicable, if not specifically designed for recovery avoiders. Greg Chasson, his families as motivators model,
Yep.
kind of does some of that. Now, that's not necessary, but that was designed more for hoarders. Um, uh, and Ellie Leibowitz's space program, which a lot of people are familiar with, is probably the closest thing to us. But it's, first of all, it's only for parents of OCD and anxious kids.
Right.
Our approach deals with, it could be your spouse that's a recovery avoider, it could be your parent. And the other difference is that our focus is not even mainly on the recovery avoider. It's on the rest of the family. And Ellie's approach is very different than that, although he has elements of what we do, but our focus is much more squarely on helping the family get emotionally well and improve their well-being. And that's for two reasons. One is, for them, they deserve just as much as the person with OCD to have a life and psychological well-being. But secondly, they're more effective
Yeah.
in dealing with a person with OCD when they are not so impaired themselves. And the fact that they do minimizing behaviors and things like that is not a reflection of, oh, they're a bad person in any way or inadequate. That's the natural result of doing all the accommodations. You burn out, and you can't be expected to deal with things diplomatically and effectively when you're in that state of being. So there are some other approaches out there. John Grayson has something called strategic pressure. I don't think it's for every family, and it's maybe some people would see it as controversial, but so there are a
John has
couple other.
never been controversial. I don't know why.
Oh no,
No, never.
no, no, no! This was a very unusual sidestep for him. Yeah, you hardly ever see that.
Yeah, never.
Uh, so, but John's got a great mind, and he always is thinking out of the box, trying to find new things. I think what we've tried to do, is, and I've said this many times, I've never had an original idea in my life. I just steal from the best people. And I think what we've tried to do is see what is available, not necessarily meant to be for people dealing with recovery avoidance, but they might have interventions that might have been invented for other reasons, but would apply to what these families are dealing with. So that's why we include the valued activities and getting family members to engage more in valued activities. And we even have a term for that, accommodations of omission. the things that people have given up because the recovery avoider. We often think about the things they do.
Yeah.
Yeah, accommodations of commission for the person that stress them and burden them. But the accommodations of omission, the valued activities that they've given up, they've lost those opportunities to replenish,
Sure.
To build up their reserves. And so we've applied that we've integrated this into the approach. Crisis intervention, we've integrated that into the approach. So we have some new terms, but beyond the terms, I think we basically used what cognitive behavioral science and family system science has offered us to put together a group of interventions to try to address this new problem, what we call the neglected victims of untreated mental illness, which are the families of recovery avoiders.
And you say you had a lot of collaborators on this book. I mean, this was a really group effort on your part to get this out there. Yeah.
It was, and that made this project a real pain in the ass.
I'm sure it did. Yeah.
Not because they're not lovely people. Yeah. I love them all. And one of them was my late wife, Heidi, who was one of the co-authors of the book, and Melanie Van Dyke and Gary Mitchell, my colleagues, and Gloria Mathis, who was a postdoc with us a number of years ago, got involved in it. And so I let me explain that maybe salty language I was using there.
Too many cooks in the kitchen sometimes. Maybe.
Yeah. I mean, this is, and anybody out there who's collaborated
absolutely
resonate to this, right? Yeah. Okay. It's probably almost always a better product because you had all these minds working together, but it does take longer and it's more of a hassle. I'm really glad I wouldn't have changed a thing that we had everybody. And I say pain in the ass with great love and affection for all my co-authors. Yeah. And believe me, if they were asked to describe working with me, it would be much
worse.
Oh, Lord. Ugly. Yeah.
Because your lovely bride, Heidi, never had an opinion on anything whatsoever. So
No, very reserved.
Yes.
Very reserved. Yes, indeed. Mm-hmm. Yes.
We miss Mom a great deal.
We do.
She was amazing. So
she was. Yeah.
Well, Alec, I want to thank you for your time today. It was awesome to get to chat as always, and not only professionally but personally. Again, for the influence on my work and my life, I thank you, and for everybody else that's out there and all the other postdocs. I'm, of course, number one postdoc, but for all the other postdocs that are out there,
2 through 300,
2 through whatever you are. We all thank you. They may disagree. I don't know. But.
Yeah. By the way, I really, really encourage people that if you're in this situation at all, and I know it sounds self-serving, but you can take my recommendation to buy the book. Trust me, I will not get rich on this. If you want to get rich, don't write a self-help.
Don't write a book. Yeah.
And if you want to guarantee a life of poverty, have 4 other co-authors. You have to split the royalties with. So you can trust me that I'm not biased. Well, okay, maybe a little. Mm-hmm. Buy the book. We don't care if you read it. Just buy it, okay? And even cooler if you read it. That would be wonderful.
That'd be awesome. Thank you, everyone, for joining us once again for another episode of the Get to Know OCD podcast. And thank you, Dr. Alec Pollard, for being our guest today. Good friend and mentor. Appreciate you being here. If you like what we talked about today, you can check us out at NOCD.com if you're looking for help for OCD, or if you have a friend or loved one who you think could benefit from this. Not only do we do exposure and response prevention-based therapy sessions for OCD, but we even have our NOCD 411 sessions. If you're interested to speak to me or someone on our clinical leadership team about what OCD is and how it might be influencing what's happening in the family. We'd be happy to chat about that. Our clinical leadership team has been amazing at training all of our therapists in the use of evidence-based treatments for OCD and related conditions. So if you're looking for help, we're here for you. Again, NOCD.com. Thanks for listening, and join us once again on a Get to Know OCD podcast. You can subscribe on our YouTube channel or anywhere where you get your favorite podcast from. We'll see you soon.